My friends, let us have a discussion on the topic that is thalassemia. Very vast topic as such. I am going to tell you how we diagnose the thalassemia as such. What are the peripheral smear findings to call the case as thalassemia? So this is one of the important hemolytic anemia, mainly due to the globin chain synthesis defect. So let us have a details of thalassemia. So always remember the triad of hemolytic anemias, that is anemia, splenomegaly, jaundice. It is a clinical triad. Why there will be anemia? Anemia is mainly due to the RBC destruction. So most of the time there will be a ineffective erythropoiesis in the bone marrow. Whatever the RBC precursors are there, they are going to get lysed. So this happens in thalassemias. This happens again in the even in the megaloblastic anemia also this will happen. So it's all because of the RBC destruction in the bone marrow. The patient will have anemia, and to compensate that, there will be increased erythropoiesis. The bone marrow will respond. It want to replenish the RBC mass, so there will be increased erythropoiesis. Sometimes even extramedullary hematopoiesis. That's why patient can have a organomegalies like splenomegaly, hepatomegaly, lymphadenopathy can be there. So splenomegaly is mainly due to the excessive workload. Most of these RBCs containing the defective RBCs will be removed from the splenic sinusoidal spaces. That is the reason why there will be a splenomegaly. And when the RBCs are get lysed, there will be accumulation of the product of hemoglobin byproducts. That is mainly the bilirubin. Bilirubin levels will be raised. So there will be serum levels of bilirubin more than 2 grams. So that results in the jaundice. Patient also presents with the jaundice. So anemia, splenomegaly and jaundice is the clinical triad for the any hemolytic anemia for that matter. So what is this thalassemia? It is a group of genetic disorders due to the defective hemoglobin synthesis. So it's mainly the decreased or absent, totally it could be even absent synthesis of the globin chain synthesis. So quantitative abnormalities of the globin chain synthesis occurs. But remember, whenever there is a reduced synthesis of one chain, there can be excessive production of the other chains. So this is what happens. Most of the consequences of thalassemia are due to the, not only due to the reduced intracellular hemoglobin, but also due to the excessive synthesis of these abnormal globin molecules. So that will accumulate and they are the ones which are more problematic. So if you see the normal hemoglobin structure as such, normal adult contains mainly hemoglobin A, which is made up of alpha 2 and beta 2. So that's the one which constitutes around 96% to 98%. Hemoglobin F levels, it will be there for almost up to 5 to 6 months of soon after the birth, but the levels will keep on decreasing after 6 months and it becomes normal by, say, normal adult hemoglobin will be there by 9 months of age. So fetal hemoglobin is the one which contains alpha 2 and gamma 2. So percentage is very, very less in adults. And hemoglobin A2 is the one which contains alpha 2 and delta 2 around 1.5 to 3.2 percentage. So this is how normal hemoglobin will be there in the adult. So the thalassemias, they are the one which are inherited as autosomal codominant fashion. That means it could be either heterozygous form or sometimes it could be homozygous form. So heterozygous in thalassemia minor, whereas homozygous form in the thalassemia major. So let us have a look on these thalassemia syndromes, beta thalassemia and alpha thalassemia. There are two types of thalassemias. As the name indicates, beta thalassemia is caused by deficient synthesis of the beta globin chains, whereas alpha thalassemia is due to the deficient alpha chain synthesis. So it's very simple. Beta thalassemia, deficiency of the beta globin chains, alpha thalassemia, deficiency of the alpha chains. But you have to remember that when beta chains are reduced in number, there will be excessive alpha chains. So hematological consequences are mainly due to not only hemoglobin synthesis is reduced, but also due to the relative excess of these unimpaired chains. That is, alpha chains are excessive in beta thalassemia, beta chains are excessive in alpha thalassemia. So something like that. So ineffective erythropoiesis occurs in the bone marrow and hemolysis mainly occurs in the spleen. So what will happen is there are a group of this thalassemia itself is a syndrome as such. There are so many types of subtypes. So there is a decreased production of the alpha or beta chains and patient will have a low hemoglobin levels and patient will have a microcytic hypochromic blood picture. So anemia will be that of microcytic hypochromic anemia. Sometimes it could be even missed as microcytic hypochromic anemia. We may think that it is iron deficiency anemia. But remember, unlike iron deficiency anemia, here the RDW will be uniform or slightly low. And there are so many peripheral smear findings by which you can make out as that it is a case of thalassemia and not iron deficiency anemia. So let us have a look on this peripheral smear findings. So this is the classical cases of thalassemia will show excess number of these RBCs. So there will be a background of microcytic hypochromic anemia. In the microcytic hypochromic anemia, there will be good number of these target cells. What are these target cells? So these are the RBCs which will show central area of hemoglobinization. Central area of hemoglobinization. Hemoglobin accumulate in the center of the RBCs. Normally, this is a hemoglobinized portion where you see central 1/3 will be pallor, so remaining will be the hemoglobinized cytoplasm. But here, the hemoglobinization occurs peculiarly in the center and peripheral rim, thin rim of hemoglobinization. So this gives a peculiar appearance. We call these RBCs as target cells. Target cells, target RBCs. So bull's eye appearance. We call it as bull's eye appearance. Very classical for the thalassemias. So whenever we see good number of these target cells, we suspect in the background of microcytic hypochromic anemia, we suspect thalassemias. See here how to differentiate iron deficiency anemia on peripheral smear wise. There are no pencil forms, there are no teardrop forms. So pencil forms are the one which you will see mainly in the iron deficiency anemia. You will not see much target cells in the iron deficiency anemia. You can see occasional. Along with that, there are other findings also by which you can conclude there are good number of polychromatophilic RBCs, they are juvenile RBCs. So whenever you see good number of polychromatophilic RBCs, so it again indicates that the reticulocyte count will be more. Nucleated RBCs, RBCs with the nucleus. So they are nothing but late normoblast which will come into the circulation. So there is a stress hematopoiesis. So hurried erythropoiesis, again it indicates that some amount of hemolytic anemia is going on. So that's why RBCs are not getting enough time in the bone marrow to get mature. They are rushing hurriedly into the circulation. Not only that, there are good number of these RBCs. We call them as fragmented RBCs. Why they are fragmented RBC occurs? Because there is a formation of hinge bodies. Hinge bodies are nothing but remnant of the nuclear material. So these hinge bodies, whenever these RBCs containing hinge bodies enter into the spleen, so spleen identifies those hinge bodies and it eats those hinge bodies. So that's why these type of RBCs which have bitten up. So these are fragmented RBCs are seen in good number in the cases of the hemolytic anemias, especially even in the thalassemias. Also, one more important finding is the basophilic stippling of the RBCs. So, but this can be also seen in other conditions like lead poisoning, and here also it is seen. They can be associated with thrombocytopenia. So, there are so many blood picture findings that you can guess, yes, it is a case of thalassemia, but we always correlate with the clinical findings. If the patient is having splenomegaly, if the patient is having jaundice, and if the patient is having peculiar that frontal bossing and X-ray showing a crew-cut appearance or so called as hair-on-end appearance. So all those clinical data we also collect before we name the patient is having thalassemia. So peripheral smear findings are equally important, and you have to correlate with the clinically. Then you will never miss the cases of thalassemias. And we have other laboratory findings like you have to differentiate it from iron deficiency anemia. But remember, the blood picture will be like that of a microcytic hypochromic anemia. So that's why the challenging entity is you have to differentiate it from iron deficiency anemia. Remember, in iron deficiency anemia, there will be pencil forms and teardrop forms. More than that, you have to look for the RDW value will be more, and MCV will be very, very less, hemoglobin will be less. And more than that, you have to do the serum iron levels, serum ferritin levels. So they will be very much reduced in iron deficiency anemia. TIBC levels will be the one which are very much raised in iron deficiency anemia. Whereas in thalassemia patients, it will not be like that. So serum iron levels, serum ferritin levels may be go up, or it may be normal. Sometimes it may be go up because they are most of the time transfusion dependent patients. So remember here, peripheral smear doesn't show any pencil cells. So By that, you can differentiate iron deficiency anemia from the thalassemia. So hinge bodies are the one which are nothing but the remnant of nuclear DNA particles, so they appear as a globin deposits, and sometimes even you can see the HBH inclusions as a golf ball cells. So let us have a look on the beta thalassemia as such. So variation in the clinical syndromes are mainly due to the variety of mutations that occurs with the beta globin chains. So terminology we use B0, B plus and B. B0 indicates the total absence of the beta chains. B plus means there is a reduced but still detectable levels of the beta chains. B, just B, if beta you write, then it indicates that normal amount of beta chains. So this is more severe form, that is total absence is a more severe form. And more than around 100 mutations have been described in a case of beta thalassemia. So it is the research process, variety of research processes are going on about the beta thalassemia as such. Impaired beta chain results in the underhemoglobinized RBCs, and they appear as microcytic and hypochromic. And meanwhile, there is unpaired and excessive alpha chains. They are the one which will precipitate to form the insoluble inclusions, especially even in the erythroblast itself they will accumulate, and we call them as hinge bodies. So these hinge bodies are seen in erythroid precursors as well as even in the peripheral blood. So these hinge body containing erythroblast, they are the one which will undergo apoptosis. They undergo lysis within the bone marrow itself. So this results in ineffective erythropoiesis. So most of these RBCs will undergo apoptotic death within the bone marrow itself. In spite of that, if the RBCs escape from the lysis of the apoptosis, lysis by apoptosis, if they don't die by apoptosis, if at all they come into the circulation, what will happen? Inclusion bearing these RBCs, they will undergo cooling and pitting by the spleen. So RBCs will be, the spleen will recognize these RBCs containing the inclusions. So it will bite. That splenic macrophages will do this particular work, and that results in the hemolysis. So have a look of this animated diagram here to understand what exactly happens in thalassemias. Normally, erythroblast contains HbA, hemoglobin A, that's adult hemoglobin, alpha 2, beta 2. So it results in the formation of the normal RBCs. So they are the one which all of us have. What happens? What is the problem in thalassemia patients? There is reduced beta chain synthesis. So beta globin synthesis is reduced, but there is relative excess of the alpha chains. Alpha chains will accumulate. They accumulate as insoluble aggregates. So the most of the problems are mainly due to the excess of these alpha chains in beta thalassemia. So such erythroid precursors which are containing these inclusions, so they will undergo death by apoptosis within the bone marrow itself. So this results in ineffective erythropoiesis. Most of the erythroblast will die in the bone marrow itself. So that's why patient will invariably will have a anemia. So to compensate anemia, what will happen? Body will try to absorb more and more iron, right? So there will be an ineffective erythropoiesis, and more absorption of iron will take place from the stomach, right, in the duodenum. So what will happen? Patient can have a hemochromatosis because of the increased iron absorption from the stomach. The patient can have a hemochromatosis. Hemochromatosis can be also caused by, because these patients are transfusion dependent. Most of the thalassemia patients are transfusion dependent. Blood transfusion, we keep on giving blood transfusion with the intention that we want to raise the hemoglobin percentage up to 10 grams. So at least 10 gram percentage, we want to maintain that particular hemoglobin percentage. So repeated blood transfusion also contribute for hemochromatosis. Unless you do iron chelation therapy, this is very common complication in patient with thalassemia. Hemochromatosis can occur in the liver, it can occur in the heart, it can occur even in the pancreas. So in pancreas, if this particular hemochromatosis if takes place, so we call it as bronze diabetes. Patient will have a peculiar skin hyperpigmentation. So bronze diabetes is mainly due to the hemochromatosis affecting the pancreas. So remember, hemochromatosis could be due to two causes. One is due to the increased iron absorption from the stomach. Second is from repeated blood transfusion for these patients. So what will happen? Because of anemia, the tissue anoxia will occur. Body will try to produce more and more extramedullary hematopoiesis. Not only that, the bone marrows, whatever the bone marrow is there, it will gets expanded. The bone marrow, the thickness of the bones, it will get expanded. This results in very peculiar appearance in thalassemia. Not only thalassemia, any hemolytic anemia, like even in sickle cell anemia, we call it as hair on end appearance. Remember this point, this is very commonly asked in the MCQs. Hair on end appearance, also called as crew cut appearance, that is the expansion of the two cortical surfaces of the bone as such. It results in expansion of the bone cavity, bone marrow. So we call it as hair on end appearance. This is X-ray finding. So this is what happens. This is a pathogenesis of the anemia and its complications in thalassemias. So beta thalassemias are characterized by marked erythropoietin secretion as a compensatory mechanism. There can be massive erythroid hyperplasia. So if at all you do bone marrow aspiration, you will see erythroid hyperplasia and nothing more than that. As such, it is not indicated that you have to do bone marrow examination in the beta thalassemia. No, there is no need of doing bone marrow examination. What you will see only erythroid hyperplasia and nothing else. No other information you can get. But if at all you want to differentiate it from iron deficiency anemia from thalassemia, yes, that time you can do that. The bone marrow iron stain is get exhausted in iron deficiency anemia, whereas it will be excessive. It will be excessive. Iron stores are excessive in the beta thalassemia because of the accumulation of more and more, absorption of more and more iron. So patient can have a increased iron content in the bone marrow. Only to prove that, you can do bone marrow aspiration in the thalassemias. And patient can have a extramedullary hematopoiesis. So extramedullary hematopoiesis, whenever I use the word, it is mainly hematopoiesis occur in the lymphoid organs like hepatomegaly will be there because of the hematopoiesis in the liver. Splenomegaly will be there. There can be even lymphadenopathy will be there. The patient can have an impairment of the bone growth. Patient can also develop a skeletal abnormality. It is all because of the hematopoiesis, excessive hematopoiesis that is taking place. So hepatomegaly, splenomegaly, lymphadenopathy, it's all indicated by, it's all due to the extramedullary hematopoiesis. Excessive dietary absorption, the one which is the important cause for the hemochromatosis. So that is about beta thalassemia. We have three major types of beta thalassemia. Clinically as well as genetically, the beta thalassemia have been classified as thalassemia major, thalassemia intermedia, and thalassemia minor. Thalassemia major, if the patient is homozygous, they will have a very severe type, beta 0. That is absolutely no beta chains. So homozygous B+, not so severe, but still it comes under severe form where they are dependent on the blood transfusion. So thalassemia major patients, beta thalassemia major patients, we have to maintain their hemoglobin percentage up to 10. So by repeated blood transfusion. Thalassemia intermedia, severe, but no regular transfusion is required. They can have B0 or B, combination of this or this one, B+ and B+. Thalassemia minor, they remain asymptomatic. They can be missed from your clinics. So thalassemia major or minor are the one who will have one normal gene. See here, one normal B gene is there. That is the one which can compensate. So they may remain asymptomatic or they can show only mild anemia. So remember, beta thalassemia major is also called as Mediterranean anemia, or we also call it as Cooley's anemia. It's very, very common and high incidence is there in the African countries and even Southeast Asia's. And anemia will manifest only after 6 to 9 months. Why? Because we have hemoglobin F that protects in the initial stages. So after the birth, when hemoglobin F will switch from hemoglobin A at the 6 to 9 months, only then patient will manifest with the signs and symptoms. And these patients will have hemoglobin of 3 to 6 gram percentage if not treated. So peripheral smear findings, you have to remember, there will be a mild to moderate degree of anisopoikilocytosis, there will be microcytic hypochromic anemia. Along with that, we have to look for the target cells. Remember, the MCQ's question can be framed on this. Target cells are very important in diagnosis of which of the following. So it is the thalassemia cases. Along with that, you can see basophilic stippling, you can see hinge bodies, you can see fragmented RBCs, what we call it as schistocytes. So have a look at this classical picture, target RBCs with the central area of hemoglobinization. So this is target RBCs, there can be even nucleated RBC. Don't think it is a lymphocyte, it is a nucleated RBC. See the hemoglobinized cytoplasm. So nucleated RBC can also be seen. So in all the cases of hemolytic anemia, what is most important is the reticulocyte count. Yes, here also reticulocyte count is increased, but below the expected level. How much you are expecting, it will not be so much. It will be below the level of expected levels. So it's mainly due to the ineffective erythropoiesis. If at all you send the blood sample for hemoglobin F estimation, it will be raised. Hemoglobin A2 levels will be normal or some slightly low or even maybe high. And what is more important X-ray finding is a crew cut or a hair-on end appearance, especially over the facial bones. So examine these patients for hepatomegaly, splenomegaly, look for hemosiderosis, sometimes even hemochromatosis can occur, which will have an organ dysfunction. Patient can have a growth retardation and death can occur if you don't treat. So most of the time these are the patients who are transfusion dependent patients. So whenever they are transfusion dependent, remember they have to treat it with the iron chelation, otherwise they will develop a grave complication, that is hemochromatosis. The treatment of choice is what? Bone marrow transplantation, provided the patient is having HLA identical sibling. So, and that sibling should be ready to give his bone marrow. So then only you can cure the thalassemia as such. So bone marrow transplantation from HLA sibling, identical sibling is the treatment of choice. And nowadays it's possible even to predict is the next baby is going to get affected or is going to born normal by doing the prenatal diagnosis, mainly by molecular DNA analysis. And beta thalassemia minor is the one which is much more common actually than the major, and they will have a peculiar resistance to the Plasmodium falciparum infections. So they may have very mild anemia or they may remain asymptomatic for many years. Again, these patients also will have a microcytic hypochromic anemia. There will be target cells, and again it is important to do the hemoglobin electrophoresis to know whether it is really a thalassemia case or something else. And hemoglobin electrophoresis will always show increased hemoglobin A2 levels in patient with the beta thalassemia minor. Hemoglobin F levels will be either normal or slightly increased. Detection of this particular entity, that is beta thalassemia minor, is important mainly to rule out iron deficiency anemia. Otherwise it appears exactly same. And sometimes it is also important for genetic counseling of the prospective mothers. Let us have a look on the second entity, that is alpha thalassemia. So as the name indicates, alpha thalassemia, there is severe deficiency of the alpha chains and there is excessive amount of beta chains. And what is more important in alpha thalassemia is the severity, it depends on the number of genes that are get affected. So out of 4 genes, how many are missing? That's the one which will decide the prognosis. Anemia is mainly due to lack of inadequate hemoglobin and excessive amount of either beta chains, gamma chains or even delta chains. Hemoglobin F is normal, it is hemoglobin alpha 2 and gamma 2. Whereas newborns with a severe alpha thalassemia will have the gamma 4. So this is one what we call it as hemoglobin BARDS. It is the one which is the most severe form of alpha thalassemia. We call it as hydrops fetalis. And adult patients who will have severe alpha thalassemia, we call them as beta 4. We also call it as HBH disease. So there are so many types, especially 4 types of alpha thalassemia depending on the number of genes that are missing. Both hemoglobin BARDS as well as hemoglobin H, they are soluble and ineffective erythropoiesis occurs. It is mild, these two are the mild, and have a look on this particular chart. So hydrops fetalis is the one where all the 4 genes, all the alpha 4 genes are missing. So such a baby is not at all viable, it is lethal in utero. HBH disease, only one is available, so it's again very severe form. It resembles like a beta intermedia. Alpha thalassemia trait where 2 are available, either in one of the genes 2 are available, or like this different combinations can be seen. Again they remain asymptomatic for a long time and they resembles the beta thalassemia minor. Silent carrier are the one who will have only one chain missing. There will not be much problem with these silent carriers. So alpha thalassemia trait is the one where there is deletion of 2 alpha globin chains, very common in Asia and even African countries. Not much of problematic cases. HBH disease, you have to remember, it is 3 out of 4 genes are get deleted. So there can be a tetramer of excess beta chain can occur, and this is the one which will have, HBH is the one which will have very high affinity for the oxygen. So it can produce the intracellular accumulations and moderate to severe asthma. The most severe form of alpha thalassemia, remember my friends, it is the hydros fetalis. So there is a deletion of all the 4 alpha genes, resulting in death of the fetus in utero. Most of the time, if at all they survive, they will again going to die within no time. So these babies will have these 4 chains that forms the bars, and which will have very high affinity for the oxygen. Fetal distress occurs in the 3rd trimester of pregnancy itself, and the born babies will have severe pallor, generalized edema, and massive hepatosplenomegaly, which is almost similar to that of erythroblastosis fetalis. So it is very difficult to differentiate sometimes hydros fetalis of the alpha thalassemia from the erythroblastosis fetalis of that of the blood RH incompatibility. Almost it appears the same. So that is most severe form of the alpha thalassemia. So remember my friends, thalassemia is the one which is very vast disease. You have to remember the pathophysiology most importantly. Once you understand the pathophysiology, you can easily understand the so many MCQs that are expected in a chapter of the thalassemias. Thank you.